Surfactant is central to postnatal lung stability. Its most important property is the ability to reduce surface tension at the air-liquid interface of the alveolus. Without it, the natural tendency of surface tension is to collapse the smallest alveoli at end expiration. By lowering that tension, surfactant stabilizes alveoli of different sizes, preventing the smallest units from emptying into larger ones. This stabilizing effect preserves functional residual capacity, the lung volume that remains after passive exhalation, which is essential for continuous gas exchange between breaths. Surfactant also improves lung compliance by making it easier for the lung to expand with each breath, directly lowering the work of breathing. Clinically, these functions explain the hallmarks of respiratory distress syndrome in preterm infants. Without adequate surfactant, alveoli collapse, compliance is poor, and functional residual capacity is lost. The infant must generate very high pressures to reopen collapsed units, leading to rapid fatigue, worsening hypoxemia, and the classic picture of grunting and retractions. Surfactant replacement therapy directly addresses these pathophysiologic deficits by restoring alveolar stability, preserving residual lung volume, and improving compliance within minutes. Surfactant not only lowers surface tension, but also ensures uniform ventilation. By spreading evenly across alveoli, it promotes simultaneous opening of lung units, limiting regions of overdistension and underinflation. This uniformity improves gas distribution and efficiency of ventilation. Surfactant also facilitates rapid alveolar expansion at low opening pressures, which reduces the energy cost of inflation and spares respiratory muscle effort in neonates with limited reserve. Beyond mechanics, surfactant plays an important role in host defense. Surfactant proteins A and D are hydrophilic molecules that bind to pathogens, enhance their clearance by macrophages, and regulate inflammatory signaling. This immune function helps protect the immature lung against bacterial and viral invasion. Clinically, these added roles explain why surfactant deficiency is not only a problem of mechanics, but also of vulnerability to infection and dysregulated inflammation, both of which contribute to lung injury and the evolution of bronchopulmonary dysplasia. About 80% of surfactant is phospholipid. The dominant molecule, dipalmitoyl phosphatidylcholine, is the key driver of reduced surface tension and alveolar stability. Unsaturated phosphatidylcholine, phosphatidylglycerol, and phosphatidylinositol add flexibility to the film, allowing it to spread and reassemble during each breath cycle. Phosphatidylglycerol has special clinical importance because its appearance in amniotic fluid late in gestation signals advanced lung maturity. These lipids create the foundation of surfactant's mechanical function, but they require proteins to organize, spread, and maintain stability. Surfactant proteins account for only 10 to 12% of the mixture, yet they are essential. SPB and SPC are hydrophobic and integrate phospholipids into the air-liquid interface, ensuring the film reforms efficiently after every breath. SPB is indispensable for forming tubular myelin and for recycling surfactant. Complete deficiency is incompatible with life. SPA and SPD are hydrophilic proteins with immune functions. They recognize and bind pathogens, enhance phagocytosis, and regulate inflammatory responses. These combined roles highlight that surfactant is not only a biophysical system, but also a component of innate lung defense. When protein function is disrupted, either genetically or by inactivation, the phospholipid film becomes unstable and host defense is impaired, producing severe clinical disease. Surfactant is synthesized by type II alveolar cells, which begin producing phospholipids and proteins early in fetal life. These components are packaged into lamellar bodies, the intracellular storage granules that hold surfactant until release. Through exocytosis, lamellar bodies discharge their contents into the alveolar space, where the material organizes into tubular myelin. This lattice structure distributes phospholipids evenly across the air-liquid interface, ensuring rapid surface activity. After each breath, a large portion of surfactant is recycled back into type II cells for reuse, while a smaller fraction is degraded in lysosomes. This cycle of synthesis, secretion, organization, and recycling is critical because the surfactant film must reform with every respiratory cycle. Clinically, disruptions at any step, synthesis, packaging, secretion, or recycling, can impair function, leading to instability and inefficient gas exchange, even if surfactant is present in adequate quantity. Surfactant production begins around 20 weeks of gestation, but amounts are too small to provide meaningful alveolar stability. Functional levels are not typically achieved until 34 to 36 weeks. This developmental trajectory explains why prematurity is the single greatest risk factor for respiratory distress syndrome. Amniotic fluid markers provide clinical windows into this maturation process. A lecithin to sphingomyelin ratio greater than 2:1 indicates maturity, while the presence of phosphatidylglycerol after 35 weeks provides stronger confirmation. Antenatal corticosteroids accelerate this process by upregulating surfactant protein expression and enhancing phospholipid synthesis. Clinically, this is why steroids given to mothers at risk for preterm delivery improve neonatal survival. They push the surfactant system closer to functional readiness, lowering the likelihood and severity of respiratory distress at birth. Multiple influences determine whether the fetal lung achieves adequate surfactant levels. Antenatal corticosteroids are the strongest positive factor, accelerating surfactant protein expression and phospholipid synthesis. Chronic intrauterine stress, such as maternal hypertension or intrauterine growth restriction, also promotes maturation, largely through increased endogenous corticosteroid release. Negative influences are more common. Prematurity leaves the surfactant system underdeveloped, while maternal diabetes delays production because fetal hyperinsulinism blunts cortisol's stimulatory effect. Inflammation and infection can impair synthesis or inactivate existing surfactant, depending on timing and severity. Sex differences have a hormonal basis. Androgens, such as testosterone, delay surfactant maturation by suppressing type 2 cell differentiation and phospholipid synthesis, whereas estrogen and cortisol enhance these processes. This explains the higher baseline risk in male infants compared with females. Epidemiologic data also show that infants of white race carry greater risk of deficiency, though the mechanisms are less clear. Clinically, awareness of these modifying factors guides both risk assessment and the use of preventive strategies, especially antenatal steroids. When surfactant is absent or inadequate, alveolar mechanics rapidly deteriorate. Increased surface tension at the air-liquid interface causes alveoli to collapse at end expiration, leading to widespread atelectasis. The lungs become stiff, with markedly reduced compliance, so each breath requires greater pressure to generate volume. Gas exchange is impaired because collapsed or fluid-filled units receive little or no ventilation while perfusion continues, producing ventilation-perfusion mismatch with hypoxemia and carbon dioxide retention. The repetitive cycle of alveolar collapse and reopening generates shear stress, which injures the epithelial lining. Damaged cells and plasma proteins accumulate, forming the eosinophilic hyaline membranes that line air spaces in classic respiratory distress syndrome. Clinically, this cascade explains why affected infants present with grunting, retractions, and cyanosis within minutes to hours after birth, and why they deteriorate without surfactant replacement. Surfactant protein B is indispensable for surface activity. It stabilizes phospholipid layers, supports tubular myelin formation, and enables efficient recycling of surfactant. Mutations causing complete SPB deficiency are inherited in an autosomal recessive pattern. Clinically, affected infants present with severe respiratory distress syndrome at birth that does not improve with exogenous surfactant therapy because the core protein required for surfactant function is missing. Pathology demonstrates widespread alveolar collapse and proteinaceous debris in the air spaces. Prognosis is dismal. Without functional SPB, the surfactant system cannot be rescued, and the only potential option is lung transplantation. This genetic defect highlights that surfactant replacement can only correct biochemical deficiency when the underlying proteins are intact, but cannot overcome fundamental structural absence of a required component. Surfactant protein C is another hydrophobic protein, but unlike SPB, complete deficiency is not universally lethal. Mutations are usually inherited in an autosomal dominant pattern, though sporadic cases occur. The clinical spectrum is broad. Some neonates present with respiratory distress syndrome soon after birth, while others develop chronic interstitial lung disease later in childhood. Unlike SPB deficiency, exogenous surfactant may provide partial benefit because SPC is important for film stability but not absolutely required for spreading. Survivors, however, remain at risk of progressive pulmonary fibrosis, reflecting the chronic injury that occurs when surfactant films are unstable over time. Clinically, SPC mutations illustrate how disruptions in surfactant proteins can create both acute neonatal disease and long-term fibrotic lung conditions, bridging the gap between neonatal and pediatric pulmonary pathology. The ABCA3 gene encodes an ATP-binding cassette transporter responsible for moving lipids into lamellar bodies, the storage form of surfactant within type 2 cells. Mutations disrupt this packaging step, so surfactant is either absent or structurally abnormal when secreted. Infants with ABCA3 deficiency typically present with severe neonatal respiratory distress syndrome that is unresponsive to exogenous surfactant because the machinery for storage and secretion is defective. Pathology shows disorganized lamellar bodies and abnormal surfactant pools. Clinical features include persistent hypoxemia and ventilator dependence from birth. Prognosis is poor, with high mortality in infancy, and the only potential long-term therapy is lung transplantation. This mutation emphasizes how surfactant dysfunction can arise not only from missing proteins, but also from failed intracellular transport, underscoring the complexity of surfactant biology. Surfactant deficiency can arise from several distinct mechanisms. Genetic causes include mutations in SPB, SPC, or ABCA3, each producing severe or chronic dysfunction depending on the role of the affected protein. Primary deficiency is most commonly due to prematurity, where type 2 alveolar cells have not yet reached functional maturity and surfactant production is inadequate. Secondary deficiency occurs when surfactant is inactivated or destroyed after birth. Meconium aspiration, pneumonia, and pulmonary hemorrhage all introduce substances, such as meconium, inflammatory exudate, or blood proteins, that deactivate the surfactant film. The common outcome across these pathways is severe hypoxemic respiratory failure that is often refractory to standard support if surfactant is not replaced. Clinically, this framework helps distinguish whether disease is driven by immaturity, genetic absence, or inactivation, each of which has different implications for therapy and prognosis. The absence or dysfunction of surfactant produces a consistent clinical picture. Onset is usually rapid, with respiratory distress emerging within minutes to hours after birth. Symptoms include cyanosis from hypoxemia, tachypnea, grunting, and retractions, all reflecting the struggle to inflate stiff, unstable lungs. Imaging typically shows low lung volumes with a diffuse ground glass appearance and prominent air bronchograms caused by air-filled conducting airways outlined against collapsed alveoli. Blood gas analysis reveals hypoxemia, hypercapnia, and respiratory acidosis as ventilation perfusion mismatch and poor compliance worsen. Without intervention, these infants progress quickly to respiratory failure. These characteristic features form the diagnostic pattern of neonatal respiratory distress syndrome and highlight the physiologic cascade described in earlier slides: loss of alveolar stability, reduced compliance, and gas exchange failure. Surfactant deficiency is the core driver of neonatal respiratory distress syndrome because high surface tension collapses alveoli, cuts functional residual capacity, and forces injurious opening pressures. Replacing surfactant reverses that physiology within minutes. Surface tension falls, compliance improves, and oxygenation rises. These changes explain the observed reductions in mortality and pneumothorax, since lower opening pressures reduce volutrauma and barotrauma and shorten exposure to high-inspired oxygen. In genetic disorders, such as complete SPB deficiency or ABCA3 defects, response to replacement is poor because the fundamental machinery for film formation or packaging is absent. Donated phospholipid cannot substitute for missing or dysfunctional proteins or intracellular transport. Long-term, when surfactant biology is impaired or repeatedly inactivated, ongoing collapse and reopening, persistent inflammation, and impaired septation produce the simplified alveolar pattern recognized in bronchopulmonary dysplasia. The clinical imperative is to correct biochemical deficiency promptly with surfactant, avoid conditions that inactivate it, and identify genetic etiologies early when a lack of response suggests a non-remediable pathway. Cortisol is the key endogenous hormone that drives fetal lung maturation. It regulates development through several mechanisms. At the cellular level, cortisol modulates sonic hedgehog signaling via the smoothened pathway, which prevents excessive proliferation of mesenchymal fibroblasts and allows epithelial and alveolar structures to differentiate normally. Cortisol also stimulates type 2 alveolar cells to produce surfactant proteins and phospholipids, directly increasing functional surfactant levels. These effects explain why antenatal corticosteroid therapy is so effective. Giving synthetic glucocorticoids to mothers at risk of preterm delivery mimics the natural surge in cortisol that occurs late in gestation, accelerating surfactant production and alveolar maturation. Clinically, this underpins the dramatic improvement in survival and reduction in respiratory distress syndrome when antenatal steroids are administered before premature birth. Vitamin D deficiency is common in pregnancy and in premature infants, and it directly influences surfactant and lung development. Type 2 alveolar cells express the vitamin D receptor, and activation of this pathway stimulates surfactant synthesis and secretion. Vitamin D also promotes fibroblast epithelial interactions that support alveolar septation, strengthening both surfactant biology and structural growth. When vitamin D is deficient, surfactant production is reduced, alveolarization is impaired, and the lung remains more vulnerable to collapse and injury. Observational studies link deficiency to increased risk of respiratory distress syndrome and bronchopulmonary dysplasia, though the strength of evidence in humans remains limited. The physiologic explanation makes the association plausible. Insufficient vitamin D signaling leaves type 2 cells less effective and alveolar growth less robust. Clinically, this highlights the potential value of maternal supplementation during pregnancy and careful attention to vitamin D status in premature infants. Vitamin A is critical for lung maturation beyond its well-known role in vision. It maintains epithelial integrity, ensuring that airway surfaces remain resilient and capable of repair after injury. Within type 2 alveolar cells, vitamin A supports both surfactant synthesis and recycling, sustaining the availability of phospholipids and proteins for film stability. It also promotes alveolarization, helping septa form and expand the surface area for gas exchange. In preterm infants, deficiency is common and has been linked to a higher incidence of bronchopulmonary dysplasia. Supplementation, often given intramuscularly to very low birth weight infants, has been shown to modestly reduce both the incidence and severity of bronchopulmonary dysplasia. The physiologic explanation is clear. Without adequate vitamin A, epithelial barriers weaken, surfactant production falters, and alveolar growth slows, leaving the immature lung vulnerable to collapse and chronic injury. Several factors that influence surfactant production can be modified to improve outcomes. Cortisol is the best established, and antenatal corticosteroids remain standard of care when preterm delivery is anticipated. They upregulate surfactant protein expression, accelerate phospholipid synthesis, and improve alveolar differentiation, directly reducing the risk of respiratory distress syndrome. Vitamin D supplementation during pregnancy may also enhance surfactant synthesis and promote alveolar growth, though human evidence is still emerging. Together, these interventions highlight a broader principle. Optimizing the hormonal and nutritional environment before and after birth reduces both the incidence and severity of surfactant deficiency, respiratory distress syndrome, and bronchopulmonary dysplasia. Clinically, recognition of modifiable influences allows targeted prevention, not just treatment, of neonatal respiratory disease. Surfactant deficiency in preterm infants arises because type 2 alveolar cells are immature and produce insufficient phospholipid and protein content. The result is alveolar collapse at end expiration, shunt physiology from poorly ventilated but perfused units, and markedly reduced compliance. These mechanics create the classic picture of stiff lungs requiring high pressures, which further injures the tissue. Replacement therapy directly addresses the underlying deficit. When exogenous surfactant is instilled into the alveoli, surface tension falls immediately, alveoli stabilize, and functional residual capacity is restored. Compliance improves within minutes, oxygenation rises, and ventilator pressures can be decreased, limiting barotrauma and volutrauma. Clinically, the rationale is straightforward. Without surfactant, alveoli cannot remain open. With surfactant, stability and efficiency are regained. This is why surfactant replacement is a cornerstone therapy for neonatal respiratory distress syndrome, and why timely administration changes the trajectory of disease. The classic indication for surfactant therapy is neonatal respiratory distress syndrome due to primary deficiency. In these infants, immature type 2 cells cannot generate adequate surfactant, and replacement is essential for survival. Secondary inactivation is another key indication. In meconium aspiration syndrome, the meconium physically coats alveoli and inactivates surfactant. Pulmonary hemorrhage introduces plasma proteins that displace surfactant from the interface, while pneumonia and sepsis add inflammatory exudates that degrade its function. In congenital diaphragmatic hernia, surfactant therapy is included in stabilization bundles, since hypoplastic lungs often have insufficient endogenous surfactant. The unifying principle is that therapy is warranted whenever surface tension cannot be controlled by the infant's own system, whether from immaturity, inactivation, or structural underdevelopment. The timing of surfactant delivery has evolved with advances in neonatal care. Prophylactic administration in the delivery room, once routine for extremely low birth weight infants, has been supplanted by early continuous positive airway pressure with selective rescue therapy. Early rescue is now preferred, defined as treatment within the first 2 hours of life when oxygen needs exceed 30 to 40% on CPAP or when rising carbon dioxide with acidosis signals inadequate ventilation. Early rescue reduces complications compared with late therapy because alveoli are stabilized before repeated collapse and reopening cause shear injury. Late rescue, given only after escalating oxygen or ventilator needs beyond the first hours, is less effective because injury is already established. Administration beyond 7 days of life provides no benefit, since disease pathways shift from acute deficiency to chronic lung injury. Clinically, this timeline emphasizes intervening early enough to alter pathophysiology rather than waiting until damage is entrenched. Natural surfactants derived from animal sources have proven superior to the early synthetic formulations because they contain analogs of SPB and SPC, which are essential for spreading phospholipids and lowering surface tension effectively. Commonly used preparations include Poractant alpha, a porcine extract, Calfactant, derived from bovine lung lavage, and Beractant, prepared from minced bovine lung. Large studies demonstrate similar overall outcomes across these products, though some data suggest Poractant alpha at a higher initial dose provides faster improvement and reduces the need for retreatment compared with lower dosing or with Beractant. The important point is that natural products function more like endogenous surfactant, restoring alveolar stability and improving compliance rapidly. Product selection is usually based on availability and institutional protocol, but awareness of dose-dependent differences allows more precise tailoring of therapy. The traditional method of surfactant delivery is direct instillation through an endotracheal tube in infants already requiring mechanical ventilation. While effective, this approach carries risks of prolonged intubation, higher ventilator pressures, and associated complications. To minimize these, the INSURE technique was developed. The infant is briefly intubated, surfactant is administered, a few positive pressure breaths are given, and the infant is then extubated to CPAP. This method is most effective in infants who can sustain spontaneous breathing after dosing. The physiologic benefit is clear. Surfactant reaches the alveoli while minimizing exposure to mechanical ventilation. The choice between traditional instillation and INSURE depends on the infant's stability and predicted ability to breathe independently. Both methods highlight the principle that the goal is not just to deliver surfactant, but to limit the duration and invasiveness of airway support whenever possible. More recent techniques aim to deliver surfactant without prolonged intubation. The most studied method is MIST or LISA, where a thin catheter is inserted while the infant remains on CPAP. This allows surfactant to reach the alveoli while spontaneous breathing continues. Trials, including the Optimus Day study, demonstrate reductions in the need for intubation, bronchopulmonary dysplasia, and even mortality, with improved outcomes lasting into early childhood. Another option is laryngeal mask airway delivery, which can be considered in larger preterm infants with moderate respiratory distress who are stable on CPAP. These methods require careful preparation, minimal premedication, often atropine with or without a small dose of analgesia, helps reduce reflex bradycardia, but deep sedation should be avoided to preserve spontaneous effort. Importantly, LISA is not appropriate for infants with severe apnea, airway instability, or those requiring immediate invasive ventilation. The physiologic principle is consistent: deliver surfactant while preserving natural breathing and minimizing ventilator-induced injury. Aerosolized surfactant has been investigated as a way to avoid intubation altogether. Early randomized trials suggested reduced intubation rates in preterm infants with mild to moderate respiratory distress, and safety studies showed feasibility using vibrating mesh nebulizers. The appeal is clear: fewer airway manipulations and the possibility of delivering surfactant during spontaneous breathing. However, deposition into the alveoli is inefficient, with less than 10% of the administered dose reaching the distal airways. This low delivery fraction explains why large multi-center trials have not shown consistent benefit in reducing bronchopulmonary dysplasia, mortality, or long-term outcomes. Efficacy appears to vary by gestational age, nebulizer design, and surfactant formulation, leaving results heterogeneous. Current guidelines from major neonatal groups agree that aerosolized surfactant remains investigational. Minimally invasive catheter-based methods, such as LISA or traditional endotracheal installation, remain the gold standards for effective delivery. Aerosolization is not recommended for routine use outside research protocols. Ongoing studies are exploring breath-synchronized nebulizers, higher dosing strategies, and optimized formulations. But until more consistent outcomes are demonstrated, aerosol delivery should not replace proven techniques. The key clinical takeaway is that while aerosolization is promising in concept, it cannot yet provide the reliable alveolar deposition needed to stabilize the preterm lung. For now, use is limited to carefully designed trials, while established delivery methods continue to define standard practice. Some infants continue to show evidence of surfactant deficiency after the first dose, requiring repeat administration. The clearest trigger is persistent oxygen need above 30% despite initial therapy. Ongoing ventilator dependence or continued signs of respiratory distress syndrome are additional indications. Redosing intervals are product-specific. Poractant alpha may be repeated every 12 hours, up to a maximum of 3 doses. Beractant every 6 hours, up to 4 total doses, and Calfactant every 12 hours, up to 3 doses. Evidence shows that multiple doses, compared with a single administration, reduce mortality and complications in infants born before 30 weeks, particularly when deficiency is severe and ongoing. Technique matters as well. If the first dose was delivered with minimally invasive surfactant therapy and oxygen remains high, repeating through the same method is reasonable. If the infant stabilizes after an INSURE dose and oxygen requirements fall, further dosing is often unnecessary. Clinically, the principle is to redose only when deficiency persists, balancing efficacy with the risks of repeated airway manipulation. Surfactant therapy has one of the strongest evidence bases in neonatology. Meta-analyses show that natural surfactant reduces the severity of respiratory distress syndrome, lowers mortality, decreases bronchopulmonary dysplasia, and reduces air leak syndromes such as pneumothorax. Physiologically, these benefits occur because alveolar stability is restored, compliance improves within minutes, and ventilator pressures can be reduced, limiting further injury. Administration is not without complications. Transient desaturation, bradycardia, or reflux can occur during dosing, usually from brief airway obstruction or vagal reflexes. Rare but serious complications include pulmonary hemorrhage and pneumothorax, often linked to fragile vasculature or malpositioned catheters, causing uneven delivery. The clinical takeaway is that surfactant offers a very high benefit to risk ratio when given by trained staff using FiO2-based thresholds. Anticipating transient events, brief bradycardia, or desaturation allows rapid correction with gentle ventilation and oxygen adjustments, ensuring safety while preserving the substantial benefits. Acute events during administration are usually related to airway obstruction or reflex responses. Transient bradycardia and desaturation often occur when the endotracheal tube is blocked by a viscous surfactant bolus or when vagal reflexes are triggered. Uneven distribution of surfactant can abruptly change compliance, producing asymmetric ventilation. Respiratory complications include pulmonary hemorrhage, most often in extremely low birth weight infants with a patent ductus arteriosus. As surfactant improves compliance, pulmonary blood flow across the ductus rises, increasing hydrostatic pressure in fragile vessels and predisposing to bleeding. If installation is poorly synchronized with ventilation, transient hypoxemia and hypercarbia may follow. Hemodynamic changes can also occur. Improved compliance shifts preload and afterload suddenly, causing brief hypotension, while increased intrathoracic pressure during dosing may raise intracranial pressure. Other risks include reflux or aspiration if the airway is not secured, and rare infection if preparations or equipment are contaminated. Clinically, preparation and technique reduce these risks. Pre-oxygenation, slow instillation, and pausing ventilation during the bolus help prevent obstruction and vagal events. Ventilator pressures must be reduced promptly after dosing to avoid volutrauma once compliance improves. Awareness of the high hemorrhage risk in infants with significant ductus shunting guides cautious monitoring and timely closure strategies. With these precautions, adverse events are minimized, and the benefits of surfactant therapy far outweigh the risks. Beyond acute complications, several practical considerations influence outcomes. Rapid improvement in compliance is expected after dosing, so ventilator settings must be adjusted proactively. Peak inspiratory pressure or delta pressure should be lowered first, followed by careful reduction in oxygen concentration to avoid volutrauma and hyperoxia. Gentle ventilation strategies are essential as the lung transitions from stiff to more compliant. Technique also matters. Pre-oxygenation, slow instillation, and pausing ventilation during the bolus reduce bradycardia and desaturation episodes. Airway protection prevents reflux or aspiration, while strict preparation protocols limit the rare risk of contamination. Importantly, the highest risk for pulmonary hemorrhage is in extremely low birth weight infants with a hemodynamically significant patent ductus arteriosus, underscoring the need for vigilant monitoring. These considerations emphasize that surfactant therapy is not a standalone intervention, but part of an integrated respiratory strategy that requires continuous reassessment of mechanics, oxygenation, and hemodynamics. Surfactant reduces alveolar surface tension, preserves functional residual capacity, and improves compliance. Its proteins divide into functional groups. SPA and SPD regulate immune defense, while SPB and SPC drive surface activity. Production begins in type 2 alveolar cells, with functional maturity reached by 34 to 36 weeks. Cortisol and vitamin D stimulate synthesis, while antenatal steroids accelerate readiness. Deficiency is most often due to prematurity, but can also occur from secondary inactivation by meconium, infection, or pulmonary hemorrhage. Genetic mutations in SPB, SPC, or ABCA3 cause severe or chronic disease unresponsive to replacement. Clinically, deficiency produces atelectasis, ventilation-perfusion mismatch, hypoxemia, and hyaline membranes. Replacement therapy reduces mortality, air leaks, and respiratory distress severity. Early rescue dosing is most effective, repeat dosing benefits persistent cases, and natural surfactants outperform early synthetics. Delivery methods now emphasize limited invasiveness, with endotracheal instillation, INSURE and MIST or LISA as standard approaches, while aerosolization remains investigational.